Recording. Good morning. Welcome, everybody, to our quarterly Health Workforce Council meeting. I'm excited to have you all join us today, and we're going to have some engaging presentations. We're admitting people into the Zoom room right now. And as we're doing that, we can move to the next slide.
Thank you, Haley. Good morning, everyone. We're happy that you all were able to join us. My name is Maria Estela Cresano, Senior Program Coordinator with the Health Improvement Partnership. And so to kick things off, we kindly ask that you share your name, title, and organization in the chat to get a sense of who's in the room with us this morning. And yeah, really excited that you all were able to join us.
Great, thank you. I didn't introduce myself. I guess I should do that. I assume everyone kind of knows who I am since I'm always emailing. We can go, yeah. So I'm Haley. I'm the Senior Workforce Development Program Manager with the Health Improvement Partnership, and we run the quarterly Health Workforce Council meetings. And we have a full agenda today, so welcome. Thank you for joining us. We're going to have a presentation from Santa Cruz Community Centers around their Pioneering Clinic First, a new family medicine residency program, continuing clinic, and then we'll have the UC Berkeley Labor Center present the 2025 Federal Reconciliation Bill with an overview and implications for healthcare in California. And then, as always, we always provide updates around the Health Workforce Council, our quarterly updates around the work groups that we've been convening and upcoming events, and then we'll close right on time at 12:30. So with that, I'm going to jump right into introducing our next presenter, Dr. Hennessy. I had the pleasure of attending the CPCA Western Regional Clinical Excellence and Leadership Conference in June, and I'm so proud to see that our local organizations were presenting at that meeting. So Santa Cruz Community Health Centers did a presentation there, and we were really thrilled to bring it back here to our Health Workforce Council meeting. So with that, Dr. Hennessy, I'll hand it over to you to introduce yourself and get started.
Hey y'all, thank you for having me today. I'm Sala. It was really fun to do that presentation at I think the longest conference name ever. I tend to be informal just in all aspects of life. I'm fine to go by Sala, Dr. Hennessy, it doesn't matter. I use she, her pronouns. And Casey Kirkhart was not able to join today, so I will be winging this solo, which I think is absolutely fine. Please feel free to interrupt, raise your hand, speak up if you have any questions as they're coming up, because I want this to be the most useful as possible for you. It's always hard for me when I'm working both in clinic and then I also spend a lot of time at the residency program. I'm currently in the role of interim associate program director, to figure out kind of level of knowledge about residency programs in general. And sometimes it varies a lot depending on personal experiences or family members. Next slide, please. Okay, so this was essentially the learning objectives we talked about at the conferences, and we talked a lot about successes and challenges of starting a new family medicine practice, which is called a continuity clinic, as part of our new family medicine residency at SCCH, which is a federal qualified health center. And I'm going to talk a lot about the clinic first model, which really is the foundation for how the program runs. And then we'll talk a little bit about strategies that we use to integrate residents into a multidisciplinary team-based care model, which is the model we use at Santa Cruz Community Health. Next. And something that can be helpful to think about is essentially what a family medicine residency is. And so family medicine residents have already finished medical school, which is typically 4 years. Some people take longer when they do additional degrees. We have one MD PhD this year who did 7 years of school. Occasionally, some primary care programs might be 3.5 years or 3 years, but that's still pretty rare. And so after you finish medical school, you then go get more specialized training. And so family medicine residency, it's typically 3 years. Our program is 3 years. It's postgraduate, meaning all of our graduates have an MD or a DO. It's a medical training program, and it speaks to 2 different bodies that manage it. So there's the ACGME, which is the Accreditation Council for Graduate Medical Education, and it has lots and lots and lots of pages about requirements of how all programs run, and then also how family medicine programs run. And then most family medicine physicians get boarded. We all set up all of our residents to get boarded in family medicine. And then they have requirements for training and beyond training, which they call competencies, requirements and procedures, requirements in other areas. And so our family medicine residents, they train very broadly. So they train in inpatient adult medicine, which they're doing at Dominican Hospital. They do inpatient and outpatient pediatrics. They do inpatient and outpatient OB care. They do gyne care, procedural training, point of care ultrasound, which is a really cool, I wouldn't say new technology necessarily, but it's finally getting integrated into primary care. Geriatric care, emergency medicine, sports medicine, orthopedics, dermatology, they're all over the place. So if you see a resident where you're at, wonderful. Thank you for hosting them. The learning is really, really incredible. Next slide. And so when I think about family medicine requirements, I really focus on continuity clinic. So continuity clinic for a family medicine resident physician is the clinic where they're PCP. And so they have their own patients. And I think about the requirements, right? This is how it's set up. So each resident has to have a primary family medicine practice. And it has to be the same practice for at least the second and third years of their education. These sites need to get approved by the ACGME. All of our residents have their family medicine practice at Live Oak Health Center. And they're required to be there for at least 40 weeks a year. And they're required to have their own panel of patients. And with those patients, they're required to see them in lots of settings. So it's not just in clinic. They see them, sometimes they're in specialty clinics. Like I was just thinking about a resident. I saw a patient of theirs with them in clinic who had been in an orthopedic clinic when the resident was there, or part of an orthopedic surgery. They go to a SNF, they do inpatient medicine, emergency medicine. And so they see these patients in lots of different settings, which is part of the learning. They have to spend at least 1,000 hours over 3 years. And their panel needs to include at least 10% pediatric patients and 10% older patients. And they need to meet continuity requirements, as we think of for a primary care practice. It's a little bit lower because they spend less time in clinic than a typical PCP would. And so by the end of their second year of residency, their continuity needs to be 30% and 40% by the end of their third year. Next slide. And really, when we think about like, why is it beneficial to host a continuity clinic? And at CPC, I was speaking, really encouraging people to be open to this. And it is really interesting that there are health centers who are looking into this. Is that family medicine physicians who train at community health centers are twice as likely to work in underserved settings after graduation. And then a third of residents who trained at an FQHC, and this is across specialties, so it's a little bit higher in family medicine, return to work at an FQHC after residency. And then when clinics have residencies, they have increased provider recruitment, they have better scope of service, and they've been shown to have a greater rate of early entry into prenatal care. And so having residents in clinic, though it's fairly complicated, it really does improve care for patients as well. Next slide. And then, of course, there's challenges. When they've studied challenges, really, they're looking at governance and administrative complexity, right? You think of all of the requirements of being an FQHC, and then you think of all the requirements from the ACGME and the ABFM for family medicine residency. That's really been the primary identified barrier, is uniting those requirements. And then sadly, and this is a little bit of an older study, there really wasn't a change between 1992 and 2007 about how many family medicine residencies included community health center continuity training in their curriculums. Next slide. And then this is just this map I think is helpful to show about where our other local family medicine residencies are. There's a residency, UCSF in San Francisco has one. There's a Napa Solano Kaiser residency, Santa Rosa residency. And so they are kind of peppered all over the place. We don't have one that's very close. Our closest one is Natividad probably, or over the hill in San Jose. And this slide really speaks to the partnership. So Morehouse School of Medicine is our sponsoring institution. And so our designated institutional officer and our graduate medical education committee and leadership is at Morehouse in Atlanta. Common Spirit Health then created a partnership with Morehouse for something called the More in Common Alliance. And More in Common Alliance is creating programs across the country in different specialties. And then Santa Cruz Community Health was selected as the continuity clinic or the family medicine practice for this residency program. Next slide. And then this just shows essentially what is happening when we think about the impact of residents in clinic. And so when residents, so PGY1 is a first year resident, they don't have very many visits per week, and they only see 5 patients at a time. Their productivity is low. And then you need a lot more preceptor, right? And so what happens is you essentially, so when you start a program, you really have a net loss in access. It costs a lot of money. You need more staff. And so it can be intimidating to start a residency program. And so we've made it through our first year, which was great. And then in the second year, right, it starts to get better, right? You're starting to get more access by having residents instead of seeing a preceptor. If I'm precepting 2 residents, they're seeing 15 patients, whereas I can only see 10 patients on my own. And then by the time you have third-year residents, they're seeing so many patients that it really starts to beneficially expand access for the clinic as well. Next slide. And then this is a little less relevant for those of us who may be local, but here is our Live Oak Health Center. We've been around for not that long as Live Oak Health Center. We moved from East Cliff. But we love being on a campus with, mid-pen housing and with the NTES and having our courtyard. And it's been a really beautiful place to care for patients. Next slide. This is essentially our clinic before we moved in. When they were planning residency clinic, there was thought that, and this is our preceptor room. Preceptors are the people who are helping residency patients. So residency is a patient. They go and the preceptor then precepts whatever happens with that patient. And here's our office space. We've had to add a lot more desks because somehow it did get very crowded. And there's our founding program director, and Dr. Casey Kirkhart was our CMO at the time, touring the worksite. Next slide. And here's our lovely first class of residents. We now have a second class of residents as well. So it's an 88 program, which means there's 8 residents per class. Here's our first class of residents. They started in June of 2024. And so they've been around for a little over a year. We then founded something called a Joint Operations Committee. We meet on a monthly basis, and it's our SCCH clinic leadership and the hospital leadership, because there is so much that goes on in terms of things that are impacting clinic and then things that are impacting the residency. In September of 2024, the Community Advisory Council was launched to really think about the impact and the benefit and the needs of our community with the residency program, rather than just kind of residents in their own path to training. Our residency is very special in that we really prioritize mission when we're recruiting residents. And we're looking for residents that want to work with our county populations and that are interested in staying. In March of 2025, we matched our second class, and then in June, that second class of 8 residents started residency. Next slide. And so then the clinic first model is really the gold standard for how to do continuity clinic and primary care with residents. And it was a model developed by the Center for Excellence in Primary Care at the UCSF. And it really has us implementing 6 actions. So the first is designing resident schedules that really prioritize continuity of care. And there's this kind of traditional tension between inpatient and outpatient duties. So first year residents, for example, are 6 days in the hospital, 12 hours a day, except for the afternoon they have continuity clinic. And it's really easy to prioritize where they're spending the most time, when really using a clinic first model prioritizes scheduling that clinic and making sure they have that protected time to see their continuity patients. The second step is developing a small core of clinic faculty. The faculty need really increases across the years. The third step is creating operationally excellent clinics. That we've been so fortunate to already have had a well-performing clinic to start off with. The fourth is to build stable clinic teams to help promote a sense of belonging. The fifth is to increase resident time spent in primary care clinic. And the sixth is to really engage residents as co-leaders of practice transformation. Next slide. And so when I think about clinic first, I really think about why it matters so much. And as I alluded to in the last slide when I was talking about it, there's this really tension between inpatient and outpatient medicine that comes up. And we have a curriculum committee that meets, and it's always like, why can't I have the resident for OR on Friday. Those are my best cases. Why does the resident have to be in clinic? And when they're in the OR, they're seeing that attending patients, right? But not doing continuity of care and doing the job that they're probably going to do for the rest of their lives. When they look at clinic first and they look at residencies that have clinic first curriculums versus residencies that don't, clinic first increases resident panel size, clinic time, total visits, and continuity. But it still is not the primary model in family medicine training, though I'm very curious to see if someone is studying whether that's trending the different direction as requirements are also changing. Next slide. And so I'm going to talk a little bit about our version of Clinic First. So when we started our first year of clinic, which was in 2024, in July of 2024, all of our first year residents, or R1s, were assigned one clinic afternoon shift per week, and that clinic didn't change. So Dr. Lopez, for example, always has clinic every single Friday afternoon. And so all of her patient panel is very used to that, and they know that. And there are people who tend to have availability on that Friday afternoon, which also improves her continuity. We also have a very select group of precepting faculty. Kind of back in the day before Clinic First came around, you would have a different person for every single half day, having people who know how clinic works, what resources we have available, how to work with our integrated behavioral health team, case management has been a really important part of it. And so we've only been using existing PCPs at SCCH to precept the residents. The other thing we did is each resident is assigned to an existing care team. We haven't split residents off like those. That's the resident clinic. This is everybody else's clinic. There has been a bit of a trend that gets talked about in the education community of physicians graduating and not being open or wanting to work with APPs, which is, in my opinion, a huge issue in primary care and particularly in underserved care. So residents are on the same care team. So in my care team, I'm on Oak. I've got, I don't know how many residents now, 4 residents, 2 PAs, a nurse, behavioral health, case management, acupuncture. And so residents are part of that, and they really see a gold standard for team-based care. And then we're engaging residents with attending site and all staff meetings. And then at our residency, we have a leadership and practice management rotation, which is in all 3 years of residency. So PGY1 is postgraduate year 1, which is the first year of residency, postgraduate year 2, and postgraduate year 3. And as part of this rotation, they're doing quality improvement projects, both in clinic and at the hospital. They're looking at different practice management, different models for primary care, and they're learning practice management skills. So things like agenda setting, and use of the EMR, and all sorts of other loveliness that often gets neglected in family medicine training. To really jump this off the ground, though, I started off with doing a faculty session about Clinic First in spring of 2024. Because we are a county that hasn't had graduate medical education, even the providers we have that have been involved with graduate medical education don't have much experience with the Clinic First model because it is a newer model and it's becoming more and more common. And then I also have been making sure that I'm really involved with residency. So in terms, on the curriculum committee, the program evaluation committee, the graduate medical education committee. Next slide. And as we shifted in the second academic year, we have more residents, more preceptors, more clinics. We're again prioritizing outpatient scheduling, continuing participation. And then something really neat that we've been able to start with the residents is pre-diabetes shared medical appointments. And so we're doing those Tuesday evening, depending on the residents involved and what language they speak. They do it instead of doing a continuity clinic that day. And so we either do English only, Spanish only, or bilingual English-Spanish appointments, and it's a 4-week series. Friday mornings, we've been running a pediatrics only clinic to help peds access and also to enhance resident pediatrics learning. And what's happening is this huge transfer of patients from attending preceptor panels to resident panels. So July 2025, 2,000 patients were transitioned onto resident panels. First year residents are only paneled at 100, but there's 8 of them, so that's 800 patients. Second year residents bump from 100 to 250, and this is all based on how much time they spend in clinic. We also have much greater preceptor needs with the incoming now started first years and the graduation of current residents to second years. And as we head into year 3, our need is going to grow as well. Next slide. Things that have really worked for us when we've been scheduling resident clinics is really prioritizing educational and clinic needs. Care team cohesion and continuity has been great. I'm obviously very biased, but we work with an amazing group of medical assistants, and we've really had the privilege to work with some of our more experienced medical assistants with residents who don't often know different types of roles. What does an MA do? What does a nurse do? When do you involve behavioral health? What is psychiatry scope? What is primary care scope? And then we think about prioritizing clinic, which from the Santa Cruz Community Health side of things is extremely important for us, is 63% of residencies that follow clinic first curricula really do that, versus 8% of residencies who would be following a traditional curriculum. Next slide. There's definitely challenges, not only just the sheer amount of change that's happening every year, but really prioritizing education and clinic needs, right? Every person says what I do is most important. And so this really comes up in curriculum committee when there's competing interests. There's a rotation, the rotation director says, I don't want to lose my resident for a day and a half a week. Residents also have a half day of didactics. But it really is having that longitudinal view of, the family medicine practice really is the primary learning environment for residents. Care team cohesion and continuity is challenging. Residents missing or not showing up for clinics happens. There's errors in schedules. There's gaps in who do you call, who do you not call? What about when you're sick? You have to notify so many different people. And then faculty availability is really hard, finding preceptors who can precept the shifts. As is the case in many places, we definitely don't have as many physicians as we'd like to have right now. And from our first year, when we only had 6 preceptor shifts per week, we're now up to 15 preceptor shifts per week, and it's going to be even more next year. Next slide. And then we look at continuity data. So I look at this every month. The goal or the requirement by the ACGME, who decides all the requirements, is that continuity needs to be 30% by the end of second year and 40% by the end of third year. This is data from I think it's like May. Their continuity is actually improved a little bit, which is interesting. And these are all of our 8 residents. And so this is our patient-sided continuity, which is really looking at when a patient sees a provider in clinic, how many of those visits that are done by their actual PCP. Next slide. And then our resident-sided continuity data. And so resident-sided continuity is of the visits or of the patients the residents are seeing, or of how many visits, what % of those are they seeing patients on their panel? And that's getting close to 30%. Next slide. And so to be very, very honest, scheduling is probably the most challenging part. I will not say that we have figured everything out. We currently have this complex spreadsheet. Every schedule changes every 4 weeks as residents start at different rotations. There's also not a lot of consistency. And so all the first year residents are listed here, and then all the rotations they're on is listed here. Then second year residents, their rotations, and then each rotation has a different amount of half days of clinic per week that residents are scheduled for. And then residents all have didactics. And then there's also, depending on how many people are in clinic and how many preceptors we have, sometimes residents are also doing telemedicine shifts next to the preceptor. And so it's been a huge lift. It's going to be even more so next year, and something we're really working on. We also run a bunch of specialty clinics out of SCCH relating to the residency program. We have a procedures clinic now, which runs every Monday. Our residents are doing colposcopy, and they've really expanded access to things like joint injections. Point of care ultrasound is getting scheduled across the board. And then we have an osteopathic manipulative treatment clinic that runs every Thursday afternoon. And then the shared medical appointments, which run Tuesdays. This block, for example, it was supposed to be bilingual. I think we only had monolingual Spanish speaking patients because the residents spoke Spanish. Next slide. Clinic preceptors is a small core of faculty. There's all this thought about preceptor-resident ratio. We tried 3-to-1, it did not work. We're at 2-to-1, and then 3 if someone is doing a telephonic shift. There's this thing called the primary care exception, or this concept, and it's a Medicare rule where if a resident has completed 6 months of residency and they're seeing a patient in continuity clinic, and so this applies primarily to family medicine residencies, the preceptor does not have to see the patient. However, in California, Medi-Cal has never endorsed it. And so depending on how conservative you are and people's risk tolerance, many clinics don't follow the primary care exception, and it's not something we do, which means that if you're precepting and you're staffing patients with a resident, you have to see every single patient in person. And so if you were to have 3 second-year residents who all see 7 patients, or they'll be seeing 8 patients, so that's 24 patients you have to see very quickly in 4 hours, which means, and you're supposed to talk about them, create the plan. And so it really limits how many residents you can supervise, and then increases the pool of preceptors we need. Next slide. In-basket management has also been a challenge. We know that for every hour of clinical FaceTime with patients, physicians on average spend 1 to 2 hours of desk time and in-basket work. There's also gender differences with in-basket load, which is relevant in family medicine because we tend to have more people who identify as women in family medicine. Patient-initiated messages in EHR workload were higher for female residents, even though residents had similar panel sizes. And then there's some studies that show that staff and patients make more requests of female PCPs. And then supervision of trainees is more complex with remote in-basket management. If a resident calls me and says, hey, this lab is abnormal, what do I do? And I'm not in my computer and I can't see another lab was abnormal, it creates a lot more opportunity for error. And then there's also the workflow errors where residents will route something. Happens all the time. I think Becca's office calling can attest to it, but they send a message to the nurses saying, schedule this patient for an appointment, which is obviously not a nurse task at our clinic. Next slide. We also had this lovely new challenge specific to us where we had a new electronic medical record. So our residents started clinic before we went live with using Epic. And then our first class of residents really did not get very much electronic medical record training. After residents finished their first month of orientation, getting all 8 of them in a room is extremely challenging to do. They have protected didactic time that's really focused on things that are things like cardiology and hypertension and not on workflows. And so that's something we've been working on. Next slide. Things that we're doing for our second class is really spending time more training. They already had a 3-hour medical record intro session. They're working with our trainer. I spent 4 hours with them as part of their clinical orientation month to really help with clinical management of different types of encounters and to practice live. And then we're doing a monthly session every 4 weeks at lunchtime for 30 minutes to provide direct support. And I feel like finally we're making some leeway. Next slide. Headway. Precepting workflows we've had to change. For example, for pap smear management, we see a lot of patients with abnormal pap smears. They all need to be precepted if they're in their first year. All abnormals are being precepted because these are really high-risk results we don't want to miss. Really meeting with all the stakeholders affected. It's really everyone in our clinic, right? Everyone from our RNs, our team medical assistants, our operations team, our billing team when residents bill things funny, and resident billing, precepting faculty, and to really work on improving some of our workflows. Next slide. Residents are in panel. This is from before the first year panel started to increase. It's been a big success. They're supposed to be paneled at 100. They're all pretty close to that, but patients will show up and want to establish. We'll say, hey, I really appreciated my encounter with you. Will you be my PCP? So of course we let them switch. And then all of it's based on FT. Next slide. But one of the challenges is the age requirement. So as a resident says to a bunch of people in their 50s, yes, I'll be your PCP. Yes, I'll be your PCP. We still need that percentage to be 10% for their pediatrics and 10% for patients over the age of 65. And what's been really interesting with these patterns is you can see residents who have their own strengths. So Dr. Matahin, for example, who I get to work with every Thursday afternoon, is impaled at 24% of patients 66 and over, because that's her talent. She really just connects better with our older patients, and they tell their friends, who then establish care with her. Whereas Dr. Lopez here has that talent with pediatric patients. And so some of it is letting residents go a little, they can go higher, but we do need to make sure that all of our residents balance out so they get the appropriate training, even if they don't have kind of that tendency towards a certain population. Next slide. Quality improvement has been a big part of the residency program. Family medicine residents are required to do a quality improvement project. In their first year of their leadership and practice management rotation, they were working with the clinic and hospital QI teams. Their first project was a longitudinal resident-to-resident project. Now they're in smaller teams working on SCCH clinic priorities for a few of the teams, and then there's a hospital-based team as well. And then they've been involved with scholarly activities, so it was really fun. We went and presented. We had a bunch of posters at the UCSF colloquium, I want to say it was in May. And one of our posters was looking at patient and resident cited continuity. Another one was looking at the resident QI project. One was looking at OMT. And then you get a chance to talk to people from a lot of different clinics and from different residency programs and medical schools, and learn a little more about what happens outside of our county. Next slide. This is the resident project, trying to connect patients who are hospitalized, particularly those who are hospitalized on the resident teaching service team, and those who were patients of Santa Cruz Community Health and following up in clinic. And really having the residents in both settings is such a gift to our patients. Seeing the residents see a patient who's extremely complex socially or medically in the hospital, and then seeing them in clinic and seeing how smoothly that visit goes, a visit that's really prone to medical error, medication error, communication challenges. And so residents were really working on getting their own patients back to see them in clinic. Next slide. We've also been providing shared educational experiences. So all our first year residents get Nexplanon training. We invite all of our SCCH PCPs who have not had Nexplanon training to attend the training. Several of them have. Some of our newer APPs come to the weekly resident didactics to do didactic learning with the residents. There's shared monthly site meetings and care team time at SCCH. We'll be talking about GLP-1s at our next all staff meeting, which both residents and our PCPs will be at. Next slide. And then point of care ultrasound. So I've gotten to get some physician training with residency funding. I completed the Society of Teachers of Family Medicine point of care ultrasound educator certificate program last year, which is very intense, but it really taught me how to teach others. We do a 2-day workshop every year with the residents. We've implemented point of care ultrasound in clinics. We're doing AAA screening now with POCUS, which is really quick and easy. I don't know that I've gotten many patients to go get their radiology scan for their AAA screening, particularly patients who haven't smoked. And so that's been a great resource for our patients. Next slide. And then this has been very much a project of Dr. Kirkhart, so I won't speak too much to it, but he and Oriana Nolan have started a community advisory council to really try to get all of our community partners together to make sure the residency is impacting our community in a positive way. Next slide. Sports physicals was a great example of collaboration. There's Nadia Lamy, our pediatric director, and there's a bunch of residents, and sports medicine, and it's been really great to offer services in our community. Here's Dr. Zane, our current program director, and Dr. Romo, now one of our second-year residents. And they talked about the impacts of the Community Advisory Council at the UCSF colloquium. Next slide. Great. Now we're at the end. Questions. And you can pull down my slides if you want, so I can see.
Sure, yeah, Marie, you can stop screen share. Any questions for Dr. Hennessy? You can put them in the chat or just feel free to unmute. You don't need to raise your hand or do anything formal. If there's no questions, it's because you did such a comprehensive overview for us. Well, we'll move on, and if you think of anything, feel free to put it in the chat, and also her email is shared, so you can also follow up via email if you go back to that slide we just had up, Maria. Thank you so much. We're so happy to have you join us today and share the update on this exciting residency program.
Thank you. Yeah, feel free to reach out at any point. I'm around.
Excellent, thank you. Okay, moving on to our next presentation. I'm excited to introduce Miranda Diaz. Many of you know, currently our workforce program is funded under the California Workforce Development Board High Road Training Partnership. And so the California Workforce Development Board hosts a community of practice for High Road Training Partnership grantees. And Miranda presented at one of those community of practice meetings. And when I heard her present, I was like, okay, we need to bring this back to our Health Workforce Council. So with that, I will pass it over to Miranda to formally introduce herself and hand it over to you to start your presentation.
Great, thanks so much for having me. It's fun to hear the presentation before mine of like actual on the ground real people doing work. I work in the policy space, and so it's often thinking about the entire state. And uh, so I love having both of these presentations next to each other. So I work at the UC Berkeley Labor Center. We do research and education related to labor and employment on issues that matter to working families in California, particularly low-income immigrant folks, families of color. And I'm the interim healthcare program director. And we are going to dive in today to an overview of the federal reconciliation bill, which I might call HR 1. And it's a massive bill. I'm going to do a very brief overview and then talk specifically about the healthcare parts of it and what those will mean for California. So that's the plan. If we go to the next slide, we've got just a big picture overview of this bill. So the top part here in orange are about the costs. And as you can see from that big orange line, right, there's a massive cost from tax cut extensions, adding $3 trillion to the national debt and giving $4.5 trillion in tax cuts. So the difference there between the 3 trillion and the 4.5 trillion are in cuts to various programs, and that's the kind of teal bars at the bottom. So you can see the biggest bar there is the $1 trillion cut to Medicaid over the next 10 years, which is the largest cut in the program's history. So broad strokes, this is what's in HR 1 in the reconciliation bill. In the next slide, we can see kind of what does that mean for families in the US. And fundamentally, it's this really large upward redistribution of resources. This slide, both of these are from the New York Times, and I just found them compelling visuals. They're using the CBO data, the Congressional Budget Office sort of analysis of what the bill would mean. What this slide is doing is it's imagining, let's take all of the households in the US and let's make 10 equally sized groups from the poorest households on the far left. These poorest households are earning on average about $23,000 a year to the richest households, the richest 10% of US households on the right. And those are folks who are earning $700,000 a year or more, or on average. And the impact of this bill for these families, you can see it's a cut to the poorest and it's a benefit to the richest. So just want to understand like what the bill does and then what its impacts are for families. In broad strokes, the rest of the presentation, I'm going to really focus on the Medicaid cuts particularly, because as we saw, that was the biggest chunk of cuts that are in HR 1. So on the next slide, I think about the federal Medicaid cuts as falling into 3 buckets. There's red tape, there's exclusion of immigrants, and then there's funding cuts. So in the red tape category, it's really reducing enrollment in Medicaid through additional red tape. The first category here, which I'm sure you've heard about, are Medicaid work requirements. So for the Medicaid expansion population, the Affordable Care Act expanded Medicaid to include folks who don't have kids at home, and some parents who have kids at home but have slightly higher incomes, like 110 to 138% FPL. That's the expansion population. And that is the population that is subject to these work requirements. Second part of red tape is making those expansion folks renew their eligibility twice a year instead of once a year, right? And so every time that someone has to jump through those hurdles to prove that they're eligible is another chance for folks to fall off the rolls. And then the third category here is both for Medicaid and for ACA enrollment, so Covered California enrollment, a number of administrative changes that will just make enrollment there more difficult, putting up barriers that make it harder rather than easier for people to either get enrolled or stay enrolled. So that's the red tape part. The second bucket here has to do with exclusion of immigrants. And this is especially excluding lawfully present immigrants from federal Medicaid and from Covered California and from Medicare. So these are folks who are here lawfully and are refugees or asylees or victims of trafficking or folks with work and student visas. So this is the Fed saying, we will no longer pay for Medicaid for these groups of lawfully present immigrants. As you know, California has expanded Medicaid coverage to all low-income residents, regardless of their immigration status. So including undocumented folks, but also including folks who have this unsatisfactory immigration status where the feds have said they won't pay. California has stepped up. So this component of HR 1 increases the number of people who will fall into that category. The third bucket of changes are funding cuts. So there are provider taxes that almost all states use to fund the state share of Medicaid, right? Because Medicaid is both administered and funded jointly by the feds and the state. These provider taxes are a really important source of funding for Medi-Cal, and the restrictions there's a lot that's uncertain about exactly what that's going to mean for California. And these are things like the MCO tax and the hospital quality assurance fee, HQAF, the MCO tax. These are terms that you might have heard or might know a whole lot about. I know sort of just enough to be dangerous. So if there's folks on the call who are expert on this, I might defer to you. But they're super important for funding, and they're at risk because of HR 1. And depending on how the details get worked out, it could leave a really big hole in the state budget. So one of the important things to understand about these changes is both how it impacts folks in Medicaid and the folks who might become uninsured, but also how it's going to impact everybody in California because of the potential for really massive holes in our state budget that will then affect everything from, the schools our kids go to any other priorities that folks have for California. In this same category are state-directed payments for providers that increase how much providers are getting for folks who they see in who are covered by Medicaid. So those are the three depressing buckets of changes to Medicaid. At the same time that all of this is happening, thanks to HR 1, there are state changes happening as well. So part of the state budget um, changes will also impact Medicaid. And on the next slide here, there is a lot of information. So big picture takeaways from this slide. Number one is just thinking about this timeline, which goes from 2025 all the way out to 2028. These changes are really drawn out. So we won't be feeling the full impact in California for years, right? So I think there's a lot of understandable uh, uncertainty and fear and worry about what this is going to mean for healthcare in our state. And those are absolutely well-founded, but it's not going to happen tomorrow. The impacts are really drawn out. The second thing to get from this slide, and I think you guys will get these slides. I did not make this one, but I find it very helpful. And so I hope it might be helpful for you too, to reference like, oh, when does that go into effect? So the federal changes are in green, and we've talked about a bunch of those in those 3 buckets I talked about on the last slide. But the state changes are the ones in the kind of bluey purple here. And those, what I want to highlight, one is a change that's happening in January of 2026, so relatively early in this timeline. And that's an enrollment freeze for undocumented adults who are 19 and above, who are in full scope Medi-Cal. So that means that, right, we had this big expansion of Medicaid, of Medi-Cal, so that undocumented folks were able to enroll. There's about 1.7 million people who are enrolled as undocumented Californians. But starting in January 2026, if they leave the program for whatever reason, they won't be able to come back in. Enrollment is frozen. And because of churn in this program and in this population, that's going to mean that the number of people who are enrolled is going to fall as the years go by. And that's going to have a big impact on the uninsured in our state. So that's one really important state change to keep in mind. In July of 2026, there's a couple other state changes that matter. One is a change in the PPS rate, which is especially important for FQHCs, right? It's how they get paid for Medicaid patients. For a group of immigrant enrollees in Medicaid, instead of getting that PPS rate, they're going to get the Medicaid managed care rate. And this is for individuals with unsatisfactory immigration status. That's what that UIS stands for. And that is both the undocumented population and folks who the feds have said they're not going to pay for Medicaid for, right? So remember when we were talking about the exclusion of immigrants, the feds are adding to that group with refugees and asylees and others. But there's already folks who are lawfully present in that group who are like green card holders who've had a green card for less than 5 years, folks with temporary protective status, and a whole host of immigrants who fall in that group. So a reduction in funding is part of that July 2026 impact, as well as the elimination of full scope dental coverage for folks with UIS who are 19 and above. Finally, in July of 2027, the state is planning to implement a $30 monthly premium for adults with unsatisfactory immigration status who are 19 to 59. And as you can imagine, folks who are in this, who are enrolled in Medicaid are low income, and paying a $30 monthly premium is absolutely going to mean that some folks drop off coverage because they can't afford it. Or they're going to have to make really big sacrifices to be able to pay that $30 monthly premium. So hopefully a helpful slide for all the kind of timeline of implementation, but also want to highlight these state changes that are happening. around the same time frame. Okay, so what are all of these changes going to mean for coverage in California? We can go to the next slide. California's made a ton of progress in covering more people, right? Implementing the Affordable Care Act, really robust Covered California enrollment, expanding Medicaid as part of the ACA, expanding Medicaid to everyone regardless of their immigration status. And that has all resulted in about 2.5 million folks being uninsured. We think about sort of what are they eligible for, like what categories are they in? The dark blue at the bottom, there are some undocumented folks who are not eligible for Medi-Cal because they earn too much and they can't enroll in Covered California. And they don't have an employer offer. So that's that sort of 500,000 group at the bottom. There's some folks who are eligible for Medi-Cal and not enrolled. Some folks who have an offer from their employer, but it's too expensive or they're not enrolled in that. And then there's folks in the orange and the gray who are eligible for Covered California, but not enrolled in it. So kind of that's the picture that we have today and is the result of a huge amount of progress in California. If we look to sort of 2028 and beyond and the impact of both HR 1 and the state changes, we're looking at the potential for more than 2 million additional uninsured folks by 2028. And that's primarily in this bright blue group of folks who should be eligible for Medi-Cal. But it's also an increase in the sort of the orange and the gray folks who are eligible for Covered California. Because in those cases, HR 1 did not include the extension of additional subsidies for folks enrolling in Covered California. So those additional subsidies that have been available for the past few years through the Inflation Reduction Act, those are going away. So folks who are in Covered California on average are going to be paying in 2026, they're going to be paying twice what they're paying today. And that's going to mean that for some folks it's unaffordable and they'll lose coverage. But really the biggest growth is among folks eligible for Medi-Cal, and that's a result of those work requirements, needing to redetermine every twice a year instead of just once a year, and then all of the state changes related to either undocumented folks or folks with unsatisfactory immigration status. The biggest change here, I mean, oh my gosh, is right. This is, I've been so proud of the, personally proud of the progress that California has made in the last decade, really, in terms of increasing access to coverage. And this is just a really stark reversal of some of that. The biggest change is really due to the work requirements. So I want to dive in there just a little bit more. And on the next slide, this is data from KFF that lets us look at, of the folks who are in Medi-Cal, how many are already working? And, about 2/3 of them are already working. And almost all of them should be exempt from these work requirements, right? They have an illness or disability, they're caregiving, they're attending school. And these are things that are, official exemptions in the law. But the question is how well any state is going to be able to implement those exemptions and keep people who should be enrolled. And what we know from other states who've experimented with work requirements is that this red tape is absolutely going to kick people off coverage, even folks who should be eligible, right? Anytime you have to interact with the system and prove that, yes, I have a disability, or yes, I'm taking care, I'm, caregiving in a way that is exempt, or I'm enrolled in this school program, that's another chance for something to go wrong in that administrative process, if the person even knows that they need to go through that administrative process, and people are going to lose coverage. What we know from these other states that have done work requirements, there's really no evidence that it increases employment. And in fact, the evidence we have is that sort of causation runs the other way, right? Having health insurance helps people get jobs and stay in jobs. So that's a little bit about the work requirements. When we kind of take all of these changes to Medicaid, at least on the federal side together, we can go on the next slide. These combined cuts in federal funding are massive. And it's still unclear exactly how big they're going to be because there's lots of details, particularly about the MCO tax, that are still unclear. And the impact is loaded really in the latter half of that 10-year time frame, but it's on the order of $20 billion plus per year. So KFF has taken the CBO estimates and sort of parceled them out across the states. They estimate $150 billion over 10 years for California. The DHCS estimates are $28.4 billion lost in federal funding. So before HR 1 had actually passed, my colleague Laurel did some analysis looking at like, what if California lost 10 to $20 billion in federal funding per year? What would that mean for jobs in the state? And we can go to the next slide with a little more detail on that paper. So we're sort of thinking about the high end of those estimates, the $20 billion, because that's more the ballpark that we're expecting. It's going to mean 217,000 lost jobs in California. And that's, 2/3 of that is direct healthcare jobs, the 134,000. Some of those are indirect jobs. So you can think about that as like industries that support healthcare. So like laundry or suppliers. And then some of that is induced demand. So, smaller grocery bills from workers who are laid off, or less spending at, um, the grocery store, rent, whatever it is, from those folks who don't either get a promotion or get a job or whatever it is. To be clear about kind of what we mean by lost jobs, it's both a reflection of the elimination of some jobs that exist today and also creation of fewer new jobs, right? Like slower than expected growth. So it's not just like we have this many jobs and we're going to absolutely lose 135,000 of them. It's kind of this was the projection and it's going to be somewhat lower. It's really too early to tell which parts of, or to predict which parts of the healthcare system are most affected. Obviously, it's not going to be uniform. But it's pretty clear that some parts of the healthcare system, like public hospitals and community clinics, are going to be among the hardest hit because those are the folks that disproportionately see Medicaid patients and some of these immigrant groups who are affected by the changes. This little note at the bottom, I'll just say, since the impacts of HR 1 are kind of backloaded in that 10-year time frame, we wouldn't actually expect the like 217,000 job loss to be in 2026, because like think back to that timeline slide. It hasn't all happened yet. It's more sort of on average, we're thinking about a $20 billion federal funding cut. What does that mean for our healthcare workforce? And I'll say this is the 135,000 healthcare jobs that we predict would be lost is between 3 and 5% of the 2.65 million healthcare jobs in the state, which is a number of healthcare jobs that includes home care, for example. So that might sound a little high to you, but we're sort of thinking holistically about what healthcare jobs are. So that was a bit of a whirlwind and a So just some of the things that we've been thinking about in trying to understand the impact in California. The next slide has just some resources. Like there are so many things I did not touch on. Um, uh, and so we have at the Labor Center's website, we have some maps, including healthcare employment by district and county, Medi-Cal enrollment. We've worked with CHCF on a Medi-Cal tracking tool that kind of looks at what is enrollment in Medi-Cal. There's like a 6-month delay, but sort of now, including enrollment in different categories, by different aid codes, enrollment by race and ethnicity, by language. And as I said, we're not expecting the bulk of these changes to happen right away, but this helps us look at, sort of what changes might we see early on if people are afraid of renewing their coverage or enrolling, what kind of changes might we see? And then just a few examples of analysis from other folks that we rely on, and that's helpful to try and get your arms around this massive piece of legislation that will have really profound impacts on our healthcare system. So with that, I will turn it back to Haley and would love discussion, questions, and to hear from you all.
Well, thank you. That was depressing, but informative. Thank you for being with us and sharing this information. I think we can stop screen share and again open it up for questions or thoughts, concerns, and no need to raise your hand. You can just unmute if you have any questions for Miranda, or feel free to drop them in the chat. And is it all right if we share your email, Miranda? If anyone has any follow-up questions, we'll be sure to include that in our follow-up email today.
Absolutely.
Probably most people like me are still digesting everything we just heard. So Grant, do you have a question or comment?
Yeah, to what extent do you think that the funding for rural hospitals will ameliorate any of this?
Yeah, so there was some funding for rural hospitals that was put in the bill. I think like half of it sort of has to be doled out uh, or apportioned relative to I don't know if it's enrollment or by state, and then half of it is more discretionary. So that I think would be concerning if I were a California rural hospital, is that we might not get our share. And it's nowhere near the size of the cuts. So yeah, it's not doesn't fully cover the cuts for rural hospitals.
Any other questions for Miranda? All right, if you think of anything, you can drop it in the chat, and we also will make sure you have Miranda's contact information. So thank you again so much for sharing with us today. And we'll move on to the next and final phase of our presentations, which is our Health Workforce Council updates, covering our last quarter. Well, we're still currently in, but July through September. So I'm going to actually pass it over to Adrian to share with us about the Monterey Bay Community Health Worker Collaborative. And we are going to try to play a video after this slide. So Adrian, I'll hand it over to you.
Hello, everyone. So sorry I'm at the buttery right now. Just wanted to share that we did get the support of the Board of Supervisors to acknowledge the community health worker workforce for our National CHW Awareness Week. And it was lovely. This is just a few of the people that were able to attend. Many more came, and we just really felt like we we're blessed to be able to have that opportunity to share and lift up this workforce that is so critical to our community's health. And then, yeah, we have a video that's not quite finalized. We're waiting for my dear friend Darlene and colleague to give us the thumbs up. But we're just so excited about this video that we've been working on, Darlene, for about a year. That is, I think, almost ready to go. And we want to just lift this up because it definitely speaks to this profession.
We're gonna play it, and hopefully it loads and for everybody and you can hear it. I think you're gonna have to unmute yourself, Maria.
You know, weeks later, he called me and said, you know what, you saved my life. And I said, really? He said, yes. I didn't know how important it was to check myself, and something that started bothering me that I thought it was insignificant, it turned to be something really serious. The wife convinced him to come. So somebody gave him, hey, go talk to Araceli. You know, she's going to help you. And I said, well, what's going on? He had never been to the doctor. He was afraid that he could have like cancer or things like that. Because he was ashamed to say that, he agreed to see a doctor. So, you know, I helped with scheduling an appointment and everything. The wife calls me and says, you know what? He went to the doctor, they found something really bad on him, but they caught it on time. And he didn't want to go that day. He thought that if you find out that he had canceled, he was gonna feel really ashamed. And every time I see him, he goes like, I'm still alive because of you. I said, no, nothing, you know, it's my job. Community workers, promotoras, we do a little bit of everything. And I think that that's the passion that I have for this position. When I started, it was just 2 of us, and now we're around 13. Since I was little, I didn't know that what I was doing is what a promotora or community health worker does now. In my particular case, I started translating for my mom. She would talk to the neighbors and the laundromat and say, oh, you know what, Araceli can do it for you. She's available to go. I'll let her go to help you translate for the doctor or whatever. And I was like, Mom, you can do it. People need it. Who do we look out to, you know? Now I think to myself, how can somebody just like bring somebody around the age of 12 and have them translate? And that's exactly what a lot of the families use. That's how everything started. That's what I've been doing all my life. I'm a daughter of an immigrant family, farm worker family, and we used to live in a migrant camp. I continue to visit the camp. We get invited to come and talk about the services we provide here at Salud. This is where I offer my assistance. With or without insurance, we assist anybody. The most important thing, it's when you build that trust and they trust you, they will ask for you. You know, maybe Araceli doesn't have an appointment open, but there's another step. No, I'll wait. I feel very supportive of Salud para la Gente, also the assistance, training, and guidance from Cabrillo College professors. And if it wasn't for them and their support, maybe I wouldn't even imagine going back to Cabrillo and getting the certification.
So yeah, we're really proud of, well, certainly being able to uplift this wonderful community health worker specifically and the important work she does. And soon that video will be on our website, and we'll be using it for promotion and other things. So yeah, thank you so much, and have a lovely day, everyone.
Thank you, Adrienne. And just a reminder, our Monterey Bay Community Health Worker Collaborative meets on almost a monthly basis. We kind of switched up the cadence a little bit to accommodate some other convenings around community health worker leadership and apprenticeship development. So if you're interested in joining us, you're welcome to reach out to me and Maria, and we'll add you to the calendar invite. And so feel free to join us. Next, we're going to just share a brief update about the Monterey Bay Nursing Clinical Education Consortium that just recently launched. We had our first meeting in June. We did an overview of the current RN and LVN training programs in the Monterey Bay region, and the consortium had a discussion around the agreement on the values and goals of the consortium moving forward, discussed clinical coordination systems criteria, and established a cadence for meeting. And so they'll be meeting bi-monthly. So the next meeting we just had in August, we had a presentation from the Centralized Clinical Placement Systems. It's called CCPS, a nonprofit system that's available for community colleges and employers to track their clinical placements. Then we continued a discussion based on that presentation around what are the criteria that we would need for a regional system. And we're sending out a survey to employers and training programs around clinical placement, systems already being used or barriers and challenges, effectiveness. And that survey we hope to wrap in early October and review the results at our next meeting, which will be October 21st. And we're also bringing in guest presenter from another nursing consortium I think it's in the, I'm blanking out. It's on the tip of my brain, but they're in another region and they're going to be presenting what their consortium has established and identified as goals. So it'll be helpful for us to learn from another consortium that's already established. The next slide, I'm going to pass over to Maria.
Thank you, Haley. Yeah, I'll update on the Health Career Pathways Committee. So the first meeting took place on August 13, where we introduced the new Health Workforce Council structure, including the recent establishment of the Monterey Bay Nursing Clinical Education Consortium that Haley just mentioned, and the Health Career Pathways Committee. We also recapped the Clinical Placement Mapping Project, a project where Dr. Gordon, Ashley Selk, and I contacted a total of 13 employers to capture clinical immersion programs in the county by survey with medical organizations and information from our schools, and to look at how we sustain our clinical pipeline developments. And so from these surveys, we had a 76.9, almost 77% success rate in responses. And then based on these responses, HIP and the K through 16 Regional Collaborative identified existing and potential opportunities to expand clinical training support in the region. And then from that meeting, we ended the meeting with a group discussion around employer engagement. And so for the next meeting, it's scheduled for Wednesday, November 5th from 10:30 to 12 via Zoom, where we will have presentations from Cabrillo College's health apprenticeship programs, their human services practicum program, medical assisting program, and the medical terminology course, which is being taught in North County high schools. And these meetings will occur on a quarterly basis.
Great, thank you. And I just looked up, the presentation we'll have at the Nursing Consortium is the Central Valley Consortium, which is Central San Joaquin Valley Clinical Education Collaborative. Speaking of collaboratives, I had the opportunity to attend the Central Coast K-16 Regional Collaboratives annual convening. I believe it was their first annual convening, bringing together all their Central Coast partners, and they featured student and industry panels, and they showcased the career pathway maps that the collaborative has been working on. It was also a great opportunity for networking. And I think, Ashley, are you still with us? Do you want to unmute and share anything about that convening?
Yes, good afternoon, everyone. Ashley Selk, the Central Coast K-16 Collaborative Coordinator. Thank you so much for attending, Haley. It was nice to have you present as we rolled out these two healthcare pathways. We are going to continue this work, and we are looking to have more industry folks at the table as we part of creating an established pathway based on the state's recommendation is to have our courses actually built and advised by industry partners. So there'll be more on that to come in the future, but we are currently working with our K-12 2-year and 4-year partners to make sure that our pathways are well aligned to create the greatest mobility in the shortest amount of time for our socioeconomically disadvantaged students. So looking forward to continuing the relationship with industry and bringing them into the work more as we continue.
Great, thank you. Next slide, please. So I want to provide a brief update on the midterm course that was initially kind of incubated from the Health Workforce Council in partnership working with Adrian and Ashlyn, two of our facilitators, Jack Michael with the Bay Area Community College Consortium. And the course was launched. It started out with 14 students in spring of 2025. I believe that's correct. It was an articulated course, which meant that it was a high school course designed in collaboration with Cabrillo College. It's now a dual enrollment course, which means it allows the high school students to simultaneously enroll with Cabrillo College and get college level credit, and it's doubled in size, which is so exciting. And the main thing that we want to share today is that course invites professional medical guest speakers to come and meet with the students. They meet Mondays from 4 to 7 p.m. at the Scotts Valley Middle School. We have the contact information here. Jonathan Sandoval will be sharing these slides, and we'll make sure this is included in the email follow-up, but they're really seeking medical professionals to come speak to the students in that class. And this is all part of our efforts to do early youth outreach and share about the various health career pathways that are available. So please do think about, joining them on a Monday evening and sharing your career pathway story. The next slide, I will pass over to Maria.
Thank you. So yeah, the Community Health Trust of Pajaro Valley is putting together a mixer. As you can see on your screen, there is an opportunity to RSVP via a QR code. I will also drop the registration in the chat, but it is taking place on Friday, September 19 from 4 to 6 at the Watsonville Public House. Yeah, if you have any questions regarding that, you can message us directly and we can forward that over to the team. But yeah, I think it's a great opportunity for you to attend. And as Haley mentioned earlier, we will be sharing the slides. And so if you don't get the RSVP form in the chat, then it's also attached in the slide. So another opportunity to register. And I'll also take this. So HIP, in collaboration with the Cabrillo Nursing Program, is hosting a half-day retreat on Friday, October 3rd for healthcare workers who are actively engaged in the field. This includes, but is not limited to, nurses, physicians, therapists, surgical techs, etc. Registration is by invite only to HIP partners and are only hosting 70 attendees. We are still seeking confirmation from 3 HIP members who need to respond to claim their tickets. The deadline is September 19, and I just saw one of our members drop off, but we will be messaging these HIP members so that way they don't miss out on this great opportunity that we're hosting.
Yeah, the event is at almost capacity, so we're really excited. This is the first time we're hosting our own half-day retreat, and we're going to have really engaging presentations from John Chuck. He's an MD who does a faculty session with the 1440 Multiversity. We're bringing in a mindfulness coach, and we're doing a Qigong session, so really excited about that event. We'll be sharing a recap of it at our next Health Workforce Council quarterly meeting. Another event that's the following day, Saturday, October 4th, UC Santa Cruz is hosting their Camposano Camposano Climate Action Conference. This is really around the work that they've done with community health workers and promotores to do an outreach to farm workers around the impacts of climate change and other health risks. So it's going to be a full day conference style event. They'll have some keynotes and panelists. They're going to do multiple breakout sessions, lunch and a catered lunch and networking. I think they're going to have breakfast as well. And they really want to focus on where the future vision and strategies for our region will turn to. It is a free event, so we encourage you to RSVP. We can share the link in the chat for that as well. And registration is open, and they are looking to accommodate, I think, somewhere around 100 people. So feel free to join if you are interested in those topics or would like to collaborate more with community health workers and the UCSC project. Next slide.
Okay, so one last event, HIP in partnership with Career College and Your Futures Are Business, invites you to table on behalf of your organization to meet with local high school and college level students at this year's Health Career Expo. The event is taking place at the Cabrillo Cafeteria on Friday, November 14th from 10 in the morning to 1 p.m. If you're interested in tabling, I'll drop the registration link in the chat, or if you'd prefer to access the form on your phone, then you can scan the QR code on your screen. We suggest you sign up soon as there are only 9 spots available.
And as a
And-
reminder, this is not a hiring fair. This is an opportunity for local health organizations to meet with young high school students and share the various health career pathways. It's a way to expose students to all the various health organizations and types of careers that fall under health organizations. And it's really gauged to, again, reach our youth early and provide information about health career pathways. So we are collaborating with Cabrillo College, and Your Future Is Our Business. I don't think Deb had to drop off, but Deb is coordinating all of the high school students attending, and Cabrillo College will be our host and offering allied health facility tours. So that was a lot. Next slide, please. Just a really kind of quick overview of everything we just shared and what the rest of this year looks like. We have our health workforce retreat on October 3rd, our Monterey Bay Nursing Clinical Education Consortium meeting on October 21st. The Monterey Bay Community Health Worker Collaborative will be meeting on October 23rd. November 5th will be the next Health Career Pathway Committee. And then November 14th, as Maria just mentioned, is the Health Career Expo. We'll have 2 more Monterey Bay Community Health Worker Collaborative meetings in November and December. And then our final Health Workforce Council convening of the year will be held in December. We're still deciding if that will be in person or virtual. We'll let you know. And we thank you all for your attendance today. Our last slide, just to update all of our virtual Health Workforce Council convenings have been recorded, and we've moved them all to a YouTube playlist. So you can, actually, Marie, why don't you go ahead and click on that? Hopefully the link works, and we'll drop it in the chat too. So this meeting today will be uploaded shortly, and all of our previous meetings since our inception, which was in June 2022, are all available on the YouTube playlist. So hopefully this makes it a little easier for people to go back and review content or find content if you're trying to find a specific presentation. It's all there. So thank you all. We're ending 5 minutes early, giving you back just a quick moment of your day, and appreciate you all. Thank you for joining us. Take care, everybody.